Hello! This is going to be education on wound care basics. Okay, we're going to start with what the integumentary system looks like. So, we have layers of skin. The epidermis, the dermis, the hypodermis, and then you have blood vessels. This is what it looks like in a cross section. Okay, excuse me. There are many types of wounds. There's a pressure wound, those aren't good. Wound over a bony prominence, usually deep tissue damage. Could be pressure with or without shear damage. Needs to be staged. See below. Venous. I don't know where below, but we'll figure that out. Venous. Lower leg wound caused by venous insufficiency. Arterial. Lower leg wound caused by peripheral vascular disease. Then there's a diabetic ulcer. Not good. Lower leg foot wound caused by diabetic neuropathy. What is? Okay, the next type of wound is a surgical secondary intentional wound. Surgical wound left open to heal by granulation tissue formation and contraction. Skin tear. The loss of the epidermis with or without partial loss of the dermis due to trauma. Not good. Other. For example, IAD, incontinence-associated dermatitis. Awful. Keep yourself clean. Wound stages. There's a stage 1. Intact skin, non-blanchable redness, firm to touch. Red-purple hues in dark skin. Stage 2. Partial thickness skin loss. Presents as an abrasion or a blister. Those aren't good either. Stage 3. Full thickness skin loss involves the subcutaneous tissue down to the fascia. Fascia is not involved, therefore no exposed muscle, tendon, or bone. Okay, next. Okay, moving right along. Stage 4. Full thickness skin loss involving the subcutaneous tissue and the fascia. There is exposed muscle, possibly tendon or bone. Really not good. Unstageable, or stage X, necrotic tissue, slough or eschar, that is covering the wound bed such that the depth of the wound bed cannot be determined. Then there's an SDTI, suspected deep tissue injury. Intact skin, dark red, purple bruise that indicated deep tissue damage, firm to touch. Not a nice thing. We want to prevent that from happening. Here's some pictures of a stage 1 through 4. You can see in a stage 1 that the skin is unbroken, but it's inflamed. A stage 2, skin is broken to the epidermis or the dermis. So we have a little bit of an opening. Then we have a stage 3. Ulcer extends to the subcutaneous fat layer. You can see that none of the bone is exposed yet. Moving on to the stage 4, the ulcer extends to the muscle or the bone. Not good. Okay. Wound measurements. Very important. When measuring a wound, we want to do length, width, and depth. The longest measurement of the wound is the length. The width is the widest measurement of the wound at right angles to length. The depth, the deepest vertical measurement from the base of the wound to the level of the skin. Sinus tract, a channel that extends from any part of the wound and tracks into deeper tissue. Document location according to a clock face. Head equals 12 o'clock, the toes equals 6 o'clock. This is also known as tunneling. Then there's undermining, a destruction of tissue that occurs underneath the intact skin of the wound perimeter. Document the location according to the clock face again. Head 12 o'clock, toes 6 o'clock. Okay, now let's talk about the wound bed description. There's pink red, clean open area with red pink tissue, just as it says. Granulation, firm, red, moist, not such a nice word, pebbled, healthy tissue. Then there's slough, dry or wet, loose or firmly attached yellow to brown dead tissue. Must be removed for new tissue to form. Eschar or escar, dry, black, brown, dead tissue. Very, very bad. Foreign body. Objects such as shooters, mesh, and hardware. Underlying structures such as fascia, tendon, and bone. Not visible, the portion of the wound that you can't visualize. Deep sinus tracts or cavities with a small opening. Other, anything that cannot place into the above categories. Now, drainage. Know your exudate. It's a beautiful picture. Amount. You describe as none, scant or small, moderate, large to copious. The description. Serous. Thin yellowish fluid, clear yellowish fluid. Sanguinous, bloody fluid. Purulent, thick cloudy fluid like pus. Other, anything you cannot place in the above categories, like example, green. Outer, after cleansing, record that presence. Stinky. Wound edges. Attached. An edge of hairs flush with the wound bed or as a sloping edge. Non-attached. Edge of hairs as a cliff. That's not nice. Rolled edge. Edge of hairs curled under. I believe that picture shows that type of edge. Epithelialization. New, pink to purple, shiny skin tissue. Okay, let's talk about peri-wound. Intact, unbroken skin. Erythema. So peri-wound is the skin surrounding the wound. Erythema, redness of the skin may be intense bright red to dark red or purple. If possible, measure in centimeters for the wound edge out. Indurated, abnormal firmness of the tissues with palpable margins. If possible, measure in centimeters from the wound edge out. Macerated, not nice. Wet, white, waterlogged tissue. It's like if you stayed in a bath too long and your skin got prune-like. Excoriated, superficial loss of tissue. Calloused, hyperkeratosis, thickened layer of epidermis, mostly in the lower leg, foot areas. Now, fragile, skin that is at risk for breakdown. Other, anything you cannot place in the above categories, of course. Pain. There's always pain associated. It is one of the vital signs. Record the wound pain as quantified on the visual analog scale, where 0 equals no pain and 10 equals excruciating pain, as described by the patient or the client. Let's talk about some common dressings you may see in the home. Hydrogels. There's alginates, hydrocolloids, foams, non-adherent island dressings, and antimicrobials. We'll get into further detail when you're in the home and you come upon these dressings if you just give us a call. We will educate you. Documentation, very, very, very important. You must document on the flow sheet the wound care, the type of wound, the site where the wound is located, the size and stage, observation, drainage, odor, surrounding tissue, and the treatment provided. Very important that all of this is documented on every visit. If you guys have any questions regarding wound care, you can contact your case manager. Thank you.